that have been involved in smoke-free families and for you guys to have a chance to really talk with each other. I'm excited if people want to share video and can really like see who've been working on this project. It looks like we have TriHealth, OSU, Crossroads, Help Me Grow, and oh my gosh, I'm sorry. Who was our last team? Michelle. I'm missing one. Nope.
So we have TriHealth, Help Me Grow, Crossroads, and OSU on the call today.
Oh, okay, I did get everyone, great. And then we have Lauren from Cradle Cincinnati. So, okay, so really quickly, some logistics. I don't think anybody's on mute. We manage that. Unless you have background noise, don't worry about that. Video is fine for today. We established that everybody's on, we know who you are. We will record the meeting just in case there's some information that you want to refer back to. So we did our welcome and introductions. I'm gonna go ahead and walk through just a little bit of the key driver diagram and some things that we wanna focus on today. And then Dr. Marcotte has a slide from OPQC data that we might just be able to refer to just to look at general smoking trends, since we are still waiting to finalize the data that we have for smoke-free families from PRAF. That will be coming shortly though. We do have new data, we have your site-specific data, and I'm happy to have any type of one-on-one coaching calls once that does go out, so you guys can see where you're at and look at that, how that compares to the aggregate. And then we will have some time to hear from Lauren Everett from Cradle Cincinnati about some of the Cincinnati-specific maternal smoking cessation resources and tools. And then the bulk of the rest of the call will be some team working time. And hopefully you'll walk away from the call today with some type of action plan, whether that's that you're kind of ready to move into a sustained situation and you're really happy with the interventions that you've implemented and established and the processes, or there's some areas you think you might still want to work on. We might set some 30 and 60-day goals for you to help with that as well. So we want to make this time valuable, and feel free to chime in at any time if there's a question that you have or something that we're not covering. So I'll walk through this quickly and then turn it over to Dr. Marcotte for a brief introduction and framing as well. So this was our original key driver diagram for the project. We have the goal of June 2020, which is that smoking among pregnant women measured in the third trimester will decrease by 15%, so from 25% to 21%. So again, as a collaborative in the aggregate, we're still assessing whether we've achieved this, and we hope to be able to share those aggregate data shortly. I know a lot, and I know I'm still new as this project's just coming into this next phase, but I know we've done quite a few of these interventions that have addressed a lot of these key drivers, and we will look through and refer back to the systems inventory shortly. But this box here, the second to last one, is something that we wanted to just spend a little time on today as far as the standardized referral process to Baby Me Tobacco Free, to other resources that might be good for referring mom earlier in pregnancy. And that's why we've invited Lauren as well from Cradle Cincinnati. Okay, so Mike, do you want to talk quickly about this slide or any other framing or data that you wanted to try to share?
Sure. I think, you know, this was presented about a year ago by Ryan Adcock, the director of Cradle Cincinnati, and it comes from a survey that's done. And I just wanted to point out that we have seen over the last 10 years or so a progressive reduction in the answers to the questions around whether or not people in the Cincinnati area are smoking cigarettes. And that's a pretty exciting piece of data that we're seeing. And, you know, we don't have current data that shows that the effects of the Smoke-Free Family Project or the Baby Me Tobacco Free or any of the other 5A interventions that we've been doing in Cincinnati are having a similar reduction effect. But I think we are seeing positive trends in Cincinnati. And so we wanted to just be able to talk about how do we continue these, what can we expect moving forward with data that we're seeing coming out. And this again is a survey that's done of women in Hamilton County and other, I think it's women who have recently been pregnant in Hamilton County. And so it's got some positive things going on about it. And I think we just want to continue that trend. So just thinking of ways to collaborate better across all of our maternity providers, especially for our highest risk patients that can benefit the most from smoking cessation. So that's it, all I want to say about it.
Thanks, Mike. So Lauren, I think you already introduced yourself, which is great. I'm going to turn it over to you just to walk through these couple slides. And again, I just want to recognize, I know that slide and then this bit of the discussion is looking at Cincinnati. Part of that is just we wanted to give an opportunity for kind of cross collaboration regionally as well, but we recognize, you know, this might be a little regional specific, and we can also look at how this might apply to other regions as well. So I'll turn it over to you, Lauren.
Great, thanks. So yeah, I'm just going to very briefly share a little bit about Cradle and the maternal smoking cessation efforts that we have going on, and where there might be opportunities perhaps to collaborate with some of the teams in the region. So quickly, as many of you likely already know, Cradle is a network of partners working to reduce infant mortality and extreme preterm birth in Hamilton County. Cradle has a number of activities, but the majority of our work stems from these three teams. So Connections is our team of community health workers and social workers that provide one-on-one support for moms. Queens Village represents our community engagement work that centers around supporting and uplifting Black women in particular. And then the piece that I manage is the Cradle Cincinnati Learning Collaborative, which the CCLC includes various care teams that we work with to improve prenatal care. And so how we engage with each team varies from like a light touch to something more intensive, but the topics we focus on are first trimester access to care, integrating community health workers and other forms of social support into the clinical care team, establishing team-based prenatal care models, and then maternal smoking cessation. So Cradle also has some communications and policy work that happens alongside the activities of these three teams. Next slide. So maternal smoking cessation is a key part of Cradle's strategic plan, and most of that work falls under or happens through the Learning Collaborative. And so I've listed some things here and we'll just highlight a few. So overall, we support the care team's implementation of smoking cessation interventions, which can vary depending on, you know, what methods or interventions they choose to use. One resource that Cradle has developed that you've probably seen is the Quit Smoking booklet that's for patients and clients. It is based on the 5 A's and is essentially a way for patients to plan or document their quit journey. And so you've probably seen it before, but I just wanted to kind of bring it forward again. I've heard that patients enjoy the booklet, and we have plenty of these. So if anyone would like some for their organization, just let me know and I can work with you to make that happen. The other thing I wanted to mention is that Queens Village has actually recently launched a neighborhood-based smoking cessation initiative. This initiative is through a grant from Interact for Health. It includes 2 parts. The first part is a 6-week group session where participants work with a clinical counselor and receive incentives as they cut back on smoking. The second piece is a series of mindfulness sessions that are centered around reducing stress and learning healthy coping skills. So, excuse me, the first wave of recruiting for the first cycle just ended, but they expect to begin recruiting for the next groups towards the end of June and then again in September. So that's definitely something that I can keep the group abreast of, as you know, something that maybe could be an additional support or resource for patients. The target audience for this is Black women, considering that's the focus for Queens Village. And then lastly, there's the Baby and Me Tobacco Free Grant. So this grant was first awarded in July 2019. It is a 1-year grant that provides incentives for pregnant women to quit smoking during pregnancy and continue to be smoke-free a year postpartum. The tobacco treatment specialists that coordinate and conduct the activities of this grant actually sit at UC, although Cradle was the recipient of the grant for the first year. And so considering this, the decision was made to move it over to UC when we reapplied for a second year. So we just got notice that we were awarded for a second year. So I will still be working with the UC team. It just won't administratively sit at Cradle anymore. And the initial goal of this grant was to have the program available to UC patients as well as patients at community-based health centers. But the process for admittedly getting this grant going took about 6 months. And then limited staffing only made it possible to have the grant at UC and the Cincinnati Health Department as it was getting off the ground. However, the plan is to expand in year 2, and year 2 starts July 1st, 2020. So my goal is to, continue to keep this group updated and work with the UC grant team to establish a referral process once possible. So the grant ideally is to have 3 tobacco treatment specialists, and there ended up being 2. So the goal is to get a third one on so that they can expand their reach and be able to take on more clients. So yeah, that's essentially everything that I wanted to share. Feel free to reach out to me anytime if you have any questions, or if there's any way that, we can support your efforts, and just hope to continue to identify ways to collaborate with others that are doing this work in the area.
Thank you so much, Lauren. Are there any questions for Lauren? I know, Christine, when we talked, that was a question about Baby Me Tobacco Free, so that was actually the impetus for us reaching out to Lauren, which was great. But do you have anything you want to ask directly?
Yeah, I thought if I remember correctly about what I know about Baby and Me Tobacco Free, there's some group visits involved. I guess, how has that been impacted with COVID-19? Are you transitioning things virtual, and what kind of platform are you using?
Yeah, so it's not group visits. They're one-on-one sessions with a tobacco treatment specialist. At least that's how it's being implemented. And so they have been connecting with patients verbally. Baby Me Tobacco Free has the CO2 monitors as part of, like, you blow into the CO2 monitor. That's how you receive your incentive. But ODH removed that requirement. So right now during this time, patients are able to just self-report their smoking.
Okay. In the past, were the tobacco treatment specialists meeting with the patients, like in the clinic, like face-to-face visits?
Yes, so they would know when the patient had an appointment. So that was part of the process of getting set up. Like Jasmine, the tobacco treatment specialist, had to get access at the Cincinnati Health Department to be able to get into their medical records and go into the clinic. And so that was kind of what took it a while to get off the ground. But yeah, so they were meeting with them during that visit time.
Yeah, I think I've been doing the 5 A's kind of worksheet template as part of one of our PDSAs for the project. And in that template, it says, was the patient referred to any resources, and it lists out the quit line, Baby and Me Tobacco Free, and tobacco treatment specialist. And at Crossroad, we don't have the latter 2. So all I've really been able to do is the quit line. And honestly, I don't know if I've had any patients actually follow through calling the quit line. So I've just been very interested in other sort of ways to engage women who are trying to quit under a lot of stress, but just need that added layer of support. So I've been interested in kind of how we can get more on the table for our patients.
Yes, definitely. And so it's definitely on our radar as we kick off year 2. So we can definitely follow up and start to think through, maybe get some of that groundwork going to prepare to be ready for the second year of the project.
Cool. Sounds good.
Lauren, thanks so much for coming on. Wondering how we go about getting the booklets, because I'd like to use them. Can you send them to us? Or?
Yes, I can. So I'll have to figure out how it works with us not being at the hospital right now. But I think we're about to start going back in like a rotation schedule. And so I can mail them.
Okay.
So I just need to know, how many you need and an address.
Awesome.
Yes.
Thank you.
Thanks, Lauren. Any other comments or any other thoughts for Christine about resources that are working well for others for referral? Okay. All right, then we will move on. So for the rest of the call, like I said, we really would love if everybody, if people want to chime in at any time and just share your experiences. I'm going to facilitate with Michelle some of the discussion and then try to help you walk away with like a concrete plan. So just to sort of establish the shared model and kind of baseline for what information we have, I realize now we're almost 6 months away from when you last did the systems inventory, but Michelle put together this great summary of everybody's individual data, looking across at all of the successes, which really are numerous, especially with teams using 5As and motivational interviewing in clinic, a lot of standardization about assessment and assisting, and some of what we just talked about, providing resources and counseling. There were some opportunities, it looked like, and some gaps where there might still be room for improvement work and testing new strategies. So some inconsistency with use of Craft 2.0. And I know, again, that's something we were able to have a one-on-one call with Christine and talk about Crossroads challenges with some of things that had to do with reimbursement, things with, working with fee-for-service versus managed care. And we've been able to connect with ODM about that as well through Alicia Brown. So if there are specific questions you have, we can continue to help with that connection. Also, we talked about this just now, the limited access to Baby Made Tobacco Free with resources, and then some opportunities maybe around the scripting and testing the pocket cards, and then the getting on-site motivational interviewing training, which I know we were in the process of working on before COVID started. So this is a bit of a baseline, again, at an aggregate level, but what we really wanted to do, since we had the time to talk a little more intimately today, was to have team discussion around what interventions you feel like have worked really well at your site, what successes you've been able to celebrate. If you want to share a bit about how you've done that might help other teams learn. And then really, what are your remaining challenges? And for things that have worked well, do you have any thoughts about how you'll sustain those efforts? Of course, we know with COVID that everything is changing. So, the idea to have this type of discussion kind of came about before all of that, but I think that's even more relevant now in terms of sustaining and making kind of timely changes to any sort of your process. And then we wanted to, again, have a little bit of time for sharing about reimbursement, if that's anything that, I know that's something we've talked with also with Lauren, with Christine about as well. And then we'll look through your process maps, those that had submitted them. Okay, so just kind of keeping some of those questions in mind. One thing that I thought would be useful is to look at the process maps that you had all submitted, and I have one from Crossroads, from TriHealth, and actually I do have OSU in here. Amy, we didn't know that you guys would be on the call, so that's great. So I'm going to unhide your slide so that I can share and walk through that with you as well. So Christine, I don't know if you are available to kind of talk through this a bit, but a couple of questions I had and I know when you put this together, again, we didn't have COVID, so it's a totally different situation, but maybe we could look through it and talk about what process is like working well, like which of these boxes you feel like are flowing the way that they're supposed to, and if there are any areas that you think maybe don't look like this anymore or are challenges, if this still is your current process. And another question would just be to think about like who owns certain roles and how that might affect sustainability if you have any type of turnover. So in terms of the current process, do you feel like this still reflects what is going on right now?
No,
Okay.
because of COVID,
Sure.
we've had to kind of change our intake process quite a bit, and just trying, we kind of, when we first started prenatal care, we had done this kind of long 45-minute visit where the OB medical provider was kind of trying to tackle everything on their own. And it just got to be really overwhelming. I think one of our kind of unique challenges is that we are not only prenatal care, we're family practice. And so all of us see kids and adults too. And so when I introduce a new prenatal care change or workflow, I think it's just super hard to adapt for, you know, our staff and our providers to adapt quickly, because there's so much other information that they're having to retain about adult care and pediatric care and processes related there. So anyway, we for a while had split that 45-minute visit up into 3 visits that were 2 weeks apart, and we handed a lot of tasks over to our nursing team. And now we're kind of flipping back to the initial way of the provider being the first stop and kind of doing as much as they can, and then kind of partnering with our nurses in a telehealth capacity. And that was kind of all due to COVID. So it's not exactly like the beginning, but I would say we have, we've changed the process quite a bit. I think.
Is it better in some ways? Like, do you think there's things that you'll keep whenever we can actually go back to like the way things
were? I think it's too early to tell. I think we've really only put out, I would even say barely 2 to 3 weeks ago that I put out like our new workflow, just because it took some time to kind of like realize what was going on and what needed change, and talking to everybody involved to get everybody on the same page. So one of the other challenges with being in a family practice is I feel like measuring things is just really slow, because pregnancy is a slow process, right? It takes 9 or 10 months for each individual patient. But then when I'm not seeing nearly as many patients as a prenatal care practice like TriHealth or, UC OBGYN. So we might see 30 new patients in a month. And so to see the effect of a change, it just takes a lot of time. So I don't know. I think that there's, it seems to be that the nurses are having some challenges with the telehealth component and just getting patients engaged. I think it sounds like the face-to-face visit is a lot more engaging for them. So I don't know. And it's going to be a hard thing to assess too, again, because the numbers are going to be small. It's going to take time. I'm really just relying on feedback from our team to kind of see how things are going.
It sounds like you're running daily PDSAs on your process, which is great to figure out what's working well. Okay, so I think that's just good to hear. Kind of obviously you were sort of forced to recreate the process and to be assessing it regularly to see if it's matching what's working for you. Are there any others on the call who are having similar type of process challenges, or any questions, anything you guys wanted to talk together about? I'm going to switch to TriHealth's process and see if anyone, I don't know, Kendall or Janet, if you have similar thoughts, if this looks totally different now, or how well this is reflecting what you want it to look like.
Hello? Can you hear me?
Yep.
Okay, I was just double checking. Oh, Janet, did you want to speak? Okay. All right. So once again, my name is Kendall Lindsay, and I am the tobacco treatment specialist with TriHealth. What we have here is about a year's work of things constantly changing, seeing what works for such a healthcare system like ours and things like that of the sort. So I definitely understand what Christine is talking about in terms of things being a little bit slow because pregnancy is a slow process and things like that, and just seeing if something works necessarily per se. From the beginning, our patient will ideally pre-COVID would go ahead and they'll make their first visit with the OB-GYN center. They will complete the initial prenatal history form, which includes a smoking history question that is first asked by our medical assistants. They either say yes or no, and then the patient will be identified as a current smoker or not. From there, as you can see, we split off. So at that point, if they are a smoker, it'll be put in the chief complaint as a nicotine dependence. So the medical doctor will be able to see, or the provider will be able to see, okay, this patient is a smoker, you need to address this as well. The expectation here at TriHealth is that literally every provider that this patient interacts with asks about their smoking. We found that when everyone asks about their smoking, the patient begins to take it a little bit more serious. I often have patients who have been smoking since adolescence. So this is already a difficult conversation to have. It's just a matter of degree of how in depth that you go. And is the patient willing to quit? Yes or no? So if the patient is willing to quit, they are referred to me. Well, they're asked if they want to speak to someone one-on-one counseling wise, or are they open to any additional help from outside resources at TriHealth? But usually they're referred to me, and we'll meet for the first time and we'll discuss, how long have you been smoking? How do you feel about smoking? A lot of motivational interviewing is used in my counseling sessions. Ideally, outside of the first visit, our sessions are about 10 to 15 minutes long. I do meet my patients during their current OB visit appointments because it's just more helpful. It's not just another appointment, and they see me as a part of the care team as well. The nurse case managers are involved heavily too. They're the ones that complete the PRAC 2.0 for my patients. I currently do not do so, but we're looking to possibly get me access to do it as well because not every single one of my patients see a nurse case manager. So overall, they'll ideally see me 5 visits during their pregnancy, but sometimes more because we all need a little bit more help these days. And then we'll also talk about just addressing some barriers. What's keeping you from quitting smoking? What's in the way? What's stressing you out? We'll begin to talk about barriers. A lot of the time, they don't view them as barriers because it's been their life for so long, so they believe that this is their norm. And part of my job is to help them figure that out and address them. I also refer them to the proper resources. Like here at TriHealth, we're so lucky. We have social workers, we have nurse case managers, we have community health workers, legal aid is here, and things like that. And often in conversation, a lot of those resources are brought up during our conversation because they'll open up to me a little bit more than they would maybe a medical doctor or a provider. It just has to be a little bit more personal of a conversation.
So Kendall, are all of these steps, do you feel like working well right now and however you've modified them for TriHealth? Since I know you said that you spent like a year with this process, do you feel like this is really like it works well and it reflects how
I think it works well. Yeah, I think it works well. Currently, in the moment, even with the COVID situation, because we've definitely worked hard to establish a workflow or establish a TriHealth way. I spent a lot of time with OPQC and we're still trying to figure out what is the TriHealth way because we get new residents every summer, so it's just like, okay, new wave of providers, what are your expectations here? And to make sure that we don't miss any of our moms. One of my biggest fears is that we have a mom that's a smoker and then we have someone on staff who isn't aware of that patient's options, and then we miss our chance to really help our moms and our babies.
Yeah.
So definitely always open to change things up because, like I said, it's a relatively new program. And we look at our gaps and our holes to figure out, okay, what's not happening and why isn't it happening? And usually we go to the root. It's a lot of hands in the pot, but that's perfect because I need the office manager to be on board so they know what's happening in their practice. They understand what resources I have around the clinic as well because I'm one person. So I think it's helped to just educate as many people on staff as possible.
Okay, any questions, other questions for Kendall? I want to make sure I get to time for us to do some planning, but this was really good to get like an overview, and then I'm happy to hear it's working well for you guys.
I have two questions actually for Kendall.
Mhm.
One is, who does the new OB visit for you guys? Is that a nurse or a provider?
I think that varies and depends on the patient. I do know a few patients that start their new OB visit with a nurse that we have here on staff,
Okay.
who is trained and knows about the Path 2.0 and things like that. But usually it's a provider as well. It's kind of a blend. I think it depends on if our patient is high risk or are they involved in our HOPE program, which is a program with some of our moms who struggle with opioid use and things like that. So things kind of vary here. And then what was your other question?
So I see on the box where it says MD is expected to complete the 5A script at every visit. How do you, I guess, ensure that that's being done? Is there a consistent prompt that they're using to kind of remind them, or is it just you feel like everybody gets it and is on board and does it without having to do any sort of reminder system?
Yeah, definitely. So we have a script in place down in the practice that the residents have access to and the providers have access to. But sometimes when they do it so much, they end up kind of winging it on their own because they're now comfortable to have that conversation. Not everyone here has had the opportunity to get the motivational interviewing training. So I kind of just, make myself available to make our providers more comfortable having that conversation. Sometimes it can be a little bit tense for them because they're already addressing so many other issues that the patient may have. So definitely just holding that expectation amongst ourselves here at TriHealth. And like I said, we'll keep a hard copy down there. That is still being tweaked. I mean, we're just really trying to figure out how to make this conversation more natural, not robotic, but we also want to push the point that we care, this is important. So we're going to keep asking you at every visit because we view this as important. Let me see. I have another question from Michelle. Are you using telehealth for all of your patients? If so, have you had any challenges or successes in patient engagement? COVID has definitely made this a little bit more difficult because now, well, to answer your question, yes, I am using telehealth usually, but it's really with my established patients. I try my best, my absolute best to meet patients in person first because having that spoken conversation over the phone is a little bit awkward and is hoping that they answer me. I have a separate line that I keep on me at all times, and it's not my desk phone. So they don't know, who is this person calling me from this cell phone? What do they want? What are they texting me about? I've never met her before. So I definitely use it with my established clients that I see on a regular basis. Luckily, I've been getting my new OB patients when they're here. We have a Volt system involved, so it's like a communication system that we use on our mobile phones, and I'm able to run downstairs and hopefully catch the patient. So it's been a lot of that due to COVID, but it seems like we're going to go back to increasing our patient load as normal. So I'm really glad that's happening.
Thanks, Kendall. All right, good questions. Yeah, and feel free to use the chat if you want to have other dialogue too. Okay, so last I have a process map from Amy, and I'm sorry, Polly, I don't think we have one from Help Me Grow. I don't know if that was, that might have been my error, but I don't know if you had done one at an earlier point, but if you want to, I'm happy to work with you on that too. But for Amy, if you're able to, do you want to just comment on how this is looking compared to what's working and going on right now and any areas that are challenging? I think we're having trouble hearing you again. Oops. Amy, I don't know if you're on the computer or the phone line, but I can't. Can anyone else hear her? Michelle, can you hear Amy?
No, I can't.
Okay.
Sorry about that. And Amy, it does look like you're joining by computer, but if you have a phone available and you'd like to try dialing in, sometimes that works better for people. So you should see on the bottom there's an audio button, and you should be able to switch over to phone and dial in. I can
Okay.
put that number.
And you can chat in too if you're able to. I don't know. Okay, so we'll go back to this if Amy's able to join. Okay, so this is the fun part that I'm doing a PDSA on, because this isn't typically how we do all of our AP calls, but and I'd like to hear if this is useful for you guys when we are done. But so what I was going to try to do is just walk through with each team some goals that you might, I have to, oh, okay, some goals that you might want to set over the next 30 to 60 days. Usually we do like a 30, 60, 90 day, but that just with everything going on, it seems like way too far ahead to plan. So, so what we did is put together this little form, and I can go ahead and just type in as we talk through things here. And you don't need to have a goal for each one of these interventions. These are just suggestions. So for instance, with the data entry, perhaps, you know, a 30-day goal might be increase the percentage of pregnant patients who have a PREF 2.0 form from 20 to 40%, if you know what your percent of data entry is right now. If you have a 5 A's goal, a motivational interviewing goal, and then other. And again, it might just be that you want to sustain the work that you've done, or something more specific. And then there is a question about how you'll measure progress, so we can talk through what that might look like as well. So let's see, somebody just joined as well. Is that you, Amy, on the phone? No, maybe not.
Yeah.
Okay. Sorry? Okay. All right. So I think this one I put for Crossroads. So Christine, do you want to talk a little bit about some of the interventions, what you think your priorities might be? And I guess, again, like this might be a COVID 30, 60-day plan. It just might be whatever is useful for you guys to focus on for the project.
Yeah, I'm struggling a little bit with kind of how to set my goal right now. I think, you know, if you would have asked me maybe 6 weeks ago, I think it would have been not, you know, decreasing our missed opportunities on the PRAF, because I've kind of alluded to the fact that some of my problem is sometimes it's hard to review data because of things are slow and we don't have a large patient population. So I definitely look at the PRAF as a tool that we can use to help kind of focus our quality improvement efforts. And especially with like, are we doing the 5 A's? Are we documenting that? So I think that's still something that we would like to work on. I think I mentioned we run into an issue because we have our nurses do the initial prenatal visit and the PRAF kind of all at the same time. But occasionally we'll have, I would say maybe a quarter of the time, we have a patient who will come in as self-pay, and their first visit will be self-pay, and then they will apply for Medicaid and get Medicaid prior to their second visit. So then they'll come back and they'll be enrolled in Medicaid. And so that's the opportunity that we're missing, is then they're coming in and they have Medicaid for the rest of their pregnancy, but we're not submitting the PRAF on those patients. And it's a significant enough number that I think when your numbers are small, you kind of need every opportunity you can get. So we had recently started, I had talked to our providers about, if you do notice a patient who is new to Medicaid, go ahead and send a patient case or like a phone note to the nurses who have access to the PRAF system, so we can still get that submitted. But again, it's only been, you know, maybe a month since we started doing that, so I don't really know how it's going yet at this point.
Okay, that sounds good. I think, yeah, that's great, and to try to do PDSA for that process. I'm wondering if there's even any way in terms of measurement to flag those patients, like you're saying, who are, oh, sorry, I'm missing, to flag those patients who are self-pay and then convert over and see specifically if you're able to increase the percent that you're enrolling? Do you think there's a way to separate them out for measurement?
I don't know. That's a hard one. I'm not sure. We might need to use claims or something, and so I don't. We have a bioinformatician that is on staff with us, so he's someone who I could kind of ask that to and see if he can answer this. I'm not sure off the top of my head if it's possible to kind of. I have my own system for flagging those patients, and I just write myself a note in the chart, and then it kind of carries through to the next visit. But I know that like not all of our providers do things in the same way, so I don't know that it's working across the board.
Okay. Any other, so that sounds like a great goal, PRAF goal. And again, like we don't have to fill all of this out right this moment, but any other things that you thought might be opportunities when you looked at your systems inventory, or any other things in the next month that would have to do with other interventions, 5Es or motivational interviewing, anything else that you think you want to focus on?
Yeah, I think, you know, the motivational interviewing is, I think, part of the monthly progress report. And I'm never quite sure like how, that's such a kind of, I think, subjective experience and like self-rating of, did I do motivational interviewing that visit? So that's one I'm struggling. I think we all want to do it, but how do you kind of hold the team accountable to that? How do you make sure all of our individual providers in their own art of medicine are actually, you know, being reminded of motivational interviewing and using the tools? I think the pocket cards are probably one thing that we could go ahead and try. But it is a harder one to measure, you know, like I can probably rate myself on how I'm doing, but how do I get an assessment of my other team members? I'm not sure.
Do others on the call have thoughts on that, and how you've, if this has been a success for you, how you're measuring the motivational interviewing and standardizing it?
This is Mike. Hi, Christine.
Hi.
You know, I think one thing could be some spot auditing of notes, just to see you know, and you could, like, each of you could take another provider and just do some spot auditing. It doesn't have to be a complete measurement, just like, you know, check in the chart. Did someone write the 5As in and show that they used the motivational interviewing? I mean, it's kind of a low fidelity way of just checking in, but it is, like you said, very much a self-assessment. Are you using, I find that it actually has changed the way that I interact with patients. I've just like built it in to be my normal way of interacting with every patient. It's very helpful. So, but I think spot checking is a way, I think we've used that in Cradle some as a suggested way to kind of look at things.
Yeah, that's a nice idea. We do peer reviews for our pediatric providers and adults, so it seems reasonable to be able to do that for prenatal as well.
Thanks, Mike. Thanks, Christine. I'm going to move on just to give everyone a couple minutes, but this is something that we'll send out to everybody. So again, like we can schedule a follow-up call if it's helpful, or you can maybe just take this to your next team meeting and think through what this might look like as well. So for TriHealth, any thoughts around where you're focusing the next month or two? Anything about measurement?
I believe, yeah, me and Dr. Marcotte, we spoke about me possibly getting access to PRAS 2.0, being able to fill out the PRAS 2.0 as well. So I think that might be able to be helpful, just to have a safety net if I do come across a patient who hasn't had it filled out yet, me being able to do it myself. Just as a backup for our nurse case managers, they do a phenomenal job. But like you said, sometimes a patient will come in, you know, first initial visit, self-pay, and then now all of a sudden they have coverage through the government. So I think that should be a priority.
Are you looking at, so for measurement, will you look at the completed percent of PRATs? Like, do you expect it to increase by you're getting access, like you said, so you don't miss anyone?
Yes.
Okay. All right.
Yes. So it was seeing, you know, necessarily how I fit. I know I spoke with my manager, Janet, and she was up for it too. We just COVID.
COVID yeah, just come in and say, I can get you that.
Okay.
Yeah.
Great.
Okay. And then for the 5A's intervention goals, I think because we have a new wave of residents coming in, we're trying to standardize this being a way of doing, but I think for the next 60 days, I will be sure to meet with the new round of residents just so they know, and hopefully that encourage them to also to get some motivational interview training just from me being present. And it's like a safe space for them to ask questions. But they already have a set schedule, so I think that's going to take me at least 60 days to probably get on their schedule. From a 30-day perspective, I'm still working on the 5A script modification for providers. The last one was okay, but we do think we can do better and possibly even shorten it, but also make it meaningful.
Okay.
And I'm sorry.
Anything about measuring those goals? Could just be you're gonna meet with your team and see if it happens.
Yeah, definitely gonna. Right. Yeah, we definitely have to meet with my team and things like that. And then for the motivational interviewing goal, I'll say the next 30 days I can still be in the clinic providing coaching to providers if they want to talk like in between patients or they run into something, helping them troubleshoot and showing them how to properly use their pocket cards that you guys sent over and getting them used to carrying them on them physically.
All right. I will move on then to Help Me Grow. Holly, are you able to come off mute?
Yes, can you hear me?
I can, thank you.
For the people that we're talking about the motivational interviewing, if you haven't had Gretchen Clark Hammond, I'd really, really highly recommend having her. She does an amazing job, and motivational interviewing is so helpful in so many different teaching patients. So I highly recommend her if you haven't gotten her yet.
Yeah, we did have her, and I agree. She was phenomenal.
Thanks, Holly, for sharing that. I'm just going to put like a 20-second plug. So we're putting together the change package. It's sort of a bit of a compilation of all of the tools that you guys have shared with us and some of the system and quality improvement work that we've done for the Smoke Free Families project. So we may be reaching out to you not just for tools, but some of that like testimonial that you think, you know, that was really valuable for you, Polly, the motivational interviewing, any other interventions that you thought worked really well. So over the next few weeks, you may get an email from me if you're comfortable having a little quote from your team or from you in there. We'd really appreciate that.
Okay.
I know I want to be conscious of time. We have about 5 minutes left. So, but I want to give you a chance. Is there 1 or 2 priorities that you think you guys might still be focusing on? And I know we had a call where you shared some of this really is moving into sustain for you.
Right.
In the project.
I'm just working on the, like we had talked about, the 6-month survey. So the data entry will get the 6-month survey completed so that when children are reaching 6 months, we are, you know, because our goal right now, we've done pretty well because this is our second go round with doing research and so on, and we've done pretty well with getting moms to stop smoking during pregnancy, but where we're seeing in moms are restarting to smoke, sometimes in the hospital right after the baby's born. They're having a cigarette after being stopped for, you know, 6 months. So we're working on the survey to see if we have kept them from restarting smoking. So I'll be working on that.
All right, great. Okay. So Mike, I don't know if you're on and just wanted to share anything, any thoughts on next steps for us in terms of our project. And also, I just was curious, you know, if this type of call is useful, even if maybe you had more time to like talk with each other a bit. I realized that we could have had more of that, but just general thoughts and if there's anything, Mike, you wanted to add just to wrap up.
Well, yeah, I mean, I'm sorry, I had to leave the call just briefly. I did a 5A's intervention with a patient by telehealth, so that was pretty exciting. I think it's really encouraging that we have our teams together. I'm so glad that Lauren was able to join. And, you know, I think we all recognize that there's value in connecting together and learning from each other. And we're kind of experimenting with the whole televisits, the webinars to try to support each other in our practices. And I think we should continue to look for ways for us to do that. We're not sure what our funder, who is Medicaid, plans for us. We do think that we will continue to get funding from them to continue to support our maternity teams across Ohio. And one of the things that we've really been thinking about is the way that this work, this intervention fits into the prematurity prevention and therefore infant mortality work, and how that smoking cessation is just one of those things that fits there. And so we hope to continue to use this project, the Smoke-Free Family Project, to continue to figure out how we can develop more and more those tools that are needed to transform the way we give prenatal care to our at-risk moms so that we can reduce prematurity and therefore reduce infant mortality. So thanks all for being on. It's really awesome to have everybody and see and hear from each of you, even if we can't be physically in the same place. So thank you.
Yeah, thanks so much, everyone. And so if there are specific areas we didn't get to touch on or, you know, people that you'd like to connect with, feel free to let us know. We can help facilitate that. I don't know if everybody even has each other's contact information, but if not, we can send that out so you have each other's key contact. And just, yeah, let us know how we can continue to connect and provide that service for you guys. So in the meantime, if you want to just keep maintaining your access to SharePoint so you can look at data and just keep in contact with us. You know, we'll still be reaching out and sending monthly progress reports, but we understand if people can't do that type of reporting at this time. So thank you so much, everyone, for joining today, and hopefully we'll talk really soon. Have a good afternoon. Lauren also just put her email address into the chat box. So Lauren, we'll send that out too with the PowerPoint slides and maybe maybe everybody's contact information on the call. Thanks, everyone. Have a great day.
Thank you.
Thank you.
Bye-bye.